Welcome, and thank you so much for joining today's third session of the Target Pulmonary Embolism Connection Forum with the American Heart Association. We hope you had a great session number two. My name is Aliza Rizvi, and I am the host for this session. This event is made possible through the American Heart Association's Target PE initiative, which is a 3-year initiative supported by NARI, now part of Stryker. I'd now like to welcome you to session 3, Building a Pulmonary Embolism Program. This session will highlight practical real-world strategies for implementing and developing and sustaining a successful PE program. We are pleased to have two speakers from Henry Ford and NYU Long Health who will share insights into their outpatient pulmonary embolism clinics, including standardized workflows for referrals and follow-ups, their team structure, and approaches to securing institutional and leadership buy-in into these programs. There will also be a panel at the end where you'll hear firsthand about models that have straightened continuity of care and improved long-term outcomes across the PE care journey for their teams and health systems. It is my pleasure now to introduce our first speaker, Dr. Vikas Aggarwal. Dr. Aggarwal is an interventional and endovascular cardiologist leading the pulmonary intervention program and PERT at Henry Ford Hospital in Detroit, Michigan. He's also an active clinical researcher with his expertise being in acute and chronic PE therapies like balloon pulmonary angioplasty and catheter thrombectomy. Dr. Aggarwal, I will now turn it over to you.
Yeah, thank you, Eliza. Yeah, I'm so happy to be here. All right, so we're going to just start with the story of a patient. We have a 49-year-old engineer who was short of breath and had a splenectomy as a teen and then had a pulmonary embolism event 5 years ago. He survived the pulmonary embolism, but he never completely recovered from his index event. He continued to work his desk job, but stopped exercising. He didn't have an oxygen requirement. Somebody did a CT scan a year later, which showed some scarring, but no acute PE. They said, your symptoms are because you're gaining weight and you're deconditioned. He got a pulmonary function test done, which were pretty much unremarkable. This is his echocardiogram, and you guys can see how the right ventricle is almost twice the size of the left ventricle. So now if you see that there is persistent RV dysfunction and or symptoms after an acute pulmonary embolism event, you should screen these patients for chronic pulmonary embolism. And the way to screen these patients for chronic pulmonary embolism is not to do a CTA or a CTPE, but to do a ventilation perfusion scan. Why? Because for chronic pulmonary embolism or chronic pulmonary vascular obstruction that's unresolved since the acute PE, a CTPE, that's the test of choice for acute PE, is only going to pick up 2/3 of these patients. So the sensitivity is 67 to 70%. On the other hand, if you do a ventilation perfusion scan, the sensitivity is about 97 to 98%. So if there is one thing I want everybody to take home after this talk is this. Get a VQ scan and follow up to look for chronic PE and not a CT. You can get a CT if you're worried about the lung parenchyma or another episode of acute PE, but not for chronic PE. Now, as you can see on this perfusion scan images, you have these moth-bitten defects all over the lung fields. This is a pathognomics finding for chronic PE, but it's not always so this classical. You may have one defect or two defects here and there. Essentially, if the perfusion is abnormal more than 3 months after your acute pulmonary embolism event, that's the definition of a chronic PE. You confirm this diagnosis by doing a pulmonary angiogram, which you can see. The picture in the middle is an OCT picture, which is showing the catheter at the 9 o'clock position, but the rest of them are intravascular webs or striations. These are the stigmata of essentially old leftover blood clots that have now turned into collagen and elastin and are causing obstruction to the blood flow. So if these patients that have chronic pulmonary embolism from the leftover clot, if they develop pulmonary hypertension, they fall in the category of group 4 pulmonary hypertension or chronic thromboembolic pulmonary hypertension. Not everybody with chronic pulmonary embolism is going to have pulmonary hypertension, but if they do, that's the worst of the worst phenotype amongst these patients. They can still be symptomatic and they still should be treated. And we should not treat them just because they don't have pulmonary hypertension. And we'll cover some of those things up later on in this talk. But chronic pulmonary embolism is essentially chronic pulmonary vascular obstruction that occurs from organized thrombus. And it can lead to pulmonary hypertension, which is called group 4 chronic thromboembolic pulmonary hypertension. So if I were to summarize the whole natural history of acute PE in one slide, this would be that slide. You have that acute PE, about half of the patients were going to have complete recovery with anticoagulation with no leftover clot or symptoms. About another 30 to 40% are going to have an abnormal VQ scan or evidence of chronic pulmonary embolism, but normal RV function and no pulmonary hypertension, the quote unquote chronic thromboembolic pulmonary disease or CTED. And then a minority, about 5% of all pulmonary embolism survivors are going to have not only chronic pulmonary embolism diagnosed with abnormal VQ scan and pulmonary angiography, but also associated pulmonary hypertension, which is the most morbid feared complication after surviving an acute pulmonary embolism. So what can we do to make the care of these patients more optimal? And our patient waited up to 5 years to get an answer as to why he was short of breath. I think the key lies in post-pulmonary embolism follow-up. The fact that you saw them as a PERT consult in the hospital should also mean that you continue to follow them in a PERT clinic, in a PE clinic, you name it, whatever you want to call it. But they need to be seen in a dedicated clinic because, the truth be told, access to primary care is a real problem in this country. And even if they have a primary care doctor, they have so many things going on that you can't expect a primary care doctor to do everything for their pulmonary embolism. If you send them to a hematologist, they only focus on hypercoagulable workup. If you send them to a pulmonologist, they only focus on the pulmonary infarction. So you actually need somebody who's going to own pulmonary embolism in the same fashion in the outpatient setting, the way we do it in the inpatient setting. So we looked at this in the Optum database a few years ago. This is a nationwide database of United Healthcare beneficiaries. And what we found in this data set of about 22,000 new diagnoses of pulmonary embolism patients from 2016 to 2018, the symptoms they reported in follow-up as entered by their providers in the medical chart were frequent. Dyspnea was all the way up to 21%, fatigue 18%, chest pain 16%, but a ventilation perfusion scan was done in a very, very small fraction of these patients to look for chronic pulmonary embolism. So this tells you as to how a chronic PE is not a rare disease. It's a rarely diagnosed disease. We don't look for it and we don't get the right test. We keep doing CTs and echoes when the test of choice is a VQ scan. So this is where our pulmonary embolism outpatient clinic comes in. So at Henry Ford Health, we established a pulmonary embolism clinic a couple of years ago. And this is what a PE clinic at our institution does. We, apart from just taking a regular symptom-based history, we do structured questionnaires with quality of life measures. You can use the PE ambulatory QOL questionnaires. You can use SF36, or the more simpler one is the post-VTE functional status scale, or PVFS. It's similar to NYHA class when it comes to scaling, or to like from 0 to 4. But apart from that, if they have persistent symptoms, if they are really, really symptomatic, we would do a 6-minute walk test. But if they are somewhat symptomatic but not severely limited, then instead of doing a 6-minute walk test, we would do a cardiopulmonary exercise test, because a 6-minute walk test is a very screwed way to assess for those who are severely limited and will oftentimes miss the mild to moderate limitation. And all this is done in our PE clinic. Now, if you do a cardiopulmonary exercise test, the big question you're trying to answer is the limitation, peripheral limitation from not exercising, skeletal muscle deconditioning and being out of shape, or it's a true cardiopulmonary limitation either from pulmonary hypertension or from chronic PE or from something else. So when we instituted this, we also went back and we looked at, so what do we know in the literature about CPET testing following an acute pulmonary embolism? And it essentially, so what we learned is that the data is very limited to single small center experience. And despite these limitations, we noticed that exercise capacity in these patients as measured by peak VO2 was significantly reduced after an acute PE, and it continued to stay reduced even beyond 6 months. So an exercise intervention or rehabilitation can really make a difference in these patients. You cannot automatically send every PE discharge to rehab because the payers won't cover for it. But if you get a CPET to show an abnormal peak VO2, so then they will. On the other hand, the ventilatory efficiency or the dead space ventilation actually was a lot improved more than 6 months compared to the first 6 months, which tells you that the anticoagulation medications continue to work beyond 6 months. And 6 months is not a magic international border that if you cross, anticoagulation will stop helping you. So in the PE clinic, this is what we do. First thing we did is that we created a dedicated order called Ambulatory Referral to Pulmonary Embolism Clinic. So within Henry Ford, and you can, as you can see in the EMR, you put in a new order at the time of discharge, and it shows up as an ambulatory referral to PE clinics that's specialty agnostic. This is it's not a referral order under cardiology, pulmonary, internal medicine, hematology. It is a standalone clinic that you can literally find an order for just by typing in pulmonary embolism in the chart. And then you can do it internal. So we only do it internal because in this medical record, if it's an external so referral, somebody internal has to put it in. But we do it routine, imperative, and urgent. Emergent is not really a thing. And then we can see them for outpatient PE management for, let's say, a low risk PE who's being discharged from the ER. We can see them for dosing, duration, need for interruption of anticoagulants if they're let's say if they're getting a knee surgery, post PE syndrome workup, post thrombotic syndrome workup for DVT, IVC filter management, and if there is an others. We do it at multiple sites, so within our health system, so you can see all those listed. And all these patients are seen by our 2 vascular medicine providers that do all these clinics. So the PE clinic at our site basically works hand in hand with the pulmonary hypertension clinic. If we see a patient in the PE clinic that has pulmonary hypertension, we refer them to the pulmonary hypertension clinic that then diagnoses and works up the CTEF. And then we are able to provide them with things like pulmonary thromboendarterectomy and balloon pulmonary angioplasty. But having the PE clinic really opens the door for those referrals. So that's sort of the nutshell. If they don't have a complete recovery after an acute PE, you have to figure out if they have chronic PE, CTEF, or just deconditioning. If they have CTEF, then they should get a pulmonary angiogram, right heart cath, a pulmonary hypertension workup so that they can get angioplasty or endarterectomy. If they don't have pulmonary hypertension, then they should get a CPET so that we can see if they have a cardiopulmonary limitation. If they do, then they get worked up the same way as a CTEF will get worked up. But if they have deconditioning and peripheral limitation, then they get worked up like a deconditioning is going to be worked up with exercise therapy and rehab. So nobody can do this so without a bunch of people on your team. So this is our pulmonary hypertension team with nurses, pharmacists, 6 physicians, nurse practitioners. We are thankful for a comprehensive SCARE designation by the PHN. And we work hand in hand with our vascular medicine colleagues, our cardiac imaging colleagues, and our cardiac surgeons. And I do all the pulmonary angioplasty procedures and the pulmonary angiograms. And then we have a dedicated coordinator, KD, for the PE program. And then so we have a dedicated liaison in the referring physician's office who helps with all the outpatient, all the out of the health system referrals to the PE clinic. And that's sort of the program in a nutshell. I think if you put all the pieces together, you will get buy-in from everybody because the institution will see the volume, institution will see the need. A program like this, a clinic like this, helps the institution in multiple different ways. Number one, it brings in the new business that it's not seeing. Number two, it actually declutters your emergency room and your hospital because the ER docs and the inpatient docs feel more comfortable discharging a patient if they know they will be seen in a specialized follow-up clinic rather than keeping them till all the boxes are checked. Number three, there's a lot of downstream revenue because you are actually able to pick up the diagnosis early, work them up, and offer them therapies. And the most importantly, this is an orphan disease that's really not getting diagnosed, and there is a huge gap in their care in the outpatient setting. And think of this whole initiative as a way to extend the multidisciplinary PERT inpatient model to the outpatient setting, where we keep working with our colleagues in a coordinated fashion so that we can help all these patients. I'm going to stop here and see if there are any questions or any comments.
Thank you so much, Dr. Aggarwal, for that great model share. We'll leave questions for after Dr. Bondarsky's presentation as well. But again, thank you so much for highlighting your PE model and the follow-up clinic as well. It's such an important reminder for us to really work with our patients and be great advocates for your patients. As a reminder to our audience, please send in any questions you have throughout the presentations, and we'll make sure to review the questions during the Q&A at the end of this session as time allows. Up next, I am very excited to welcome our second speaker, Dr. Eric Bondarsky. Dr. Bondarsky is a pulmonologist, critical care specialist, and the director of the PE clinic at NYU Long Health. He's also a pulmonary hypertension director at Bellevue Hospital Center and assistant director of critical care at NYU Orthopedic Hospital. Dr. Bondarsky specializes in complex pulmonary vascular disease and has advanced expertise in critical care ultrasounds and echocardiography. Dr. Bondarsky, I will pass it over to you now.
Thank you. Thank you for that wonderful introduction. Thank you, Dr. Aggarwal, also for addressing this important topic. I actually think I've heard you speak at the National PERT Conference before as well, but nice to be speaking alongside you today. So much of what I'll be talking about will be kind of like the nuts and bolts of how to build a PE program. Not to say that I'm necessarily an expert in this particular thing, but we have done that here, and I'd like to just share our experiences with you, and hopefully you can use those experiences to your benefit when setting up a PE program or a PE clinic wherever you are. With the caveat, of course, that every hospital system will be different, and some things that work for certain institutions or certain regions or certain countries may work differently than the way we do it. But hopefully, a lot of the same messages will also apply. Let's see. Okay, so a little bit of history. So the way it kind of started at NYU Langone is that two ICU doctors on the top of the screen, Dr. Nancy Amoroso and Dr. Ron Goldenberg, saw an unmet need. And until June 2021, they were kind of the chiefs of the PE clinic here, which the way it looked was because they were in the ICU for, I think, 100% of their time efforts. They were able to create a clinic that met in the hospital on certain days of the week, where they would guarantee that anybody who left our hospital with a pulmonary embolism that required follow-up, they would be able to see them in rapid order in a certain location in the hospital. However, due to institutional rearrangements and the fact that their office then had to move off campus, they were looking for a new home for the PE patients. And that's where Dr. Dweck and I, as you can see in the bottom of the screen, took over in about June of 2021. And we are also off-site, but we are hybrid doctors where we specialize in where we do some critical care in the inpatient side, but we also do some outpatient. We have an established pulmonary clinic on the outpatient side as well. So we try to integrate the PE clinic into our pre-existing workflow, and it has evolved quite a bit since 2021. So this is a little bit of numbers of how we've seen our growth. I will draw your attention first to the blue dot, so the blue graph rather. So it's a patient or visit count from 21-22, as you can see in that fiscal year, well below 100 when we first started. By 22-23, the new patients went up between 1 and 200, and that kind of stayed pretty steady between 150 and 170, give or take, for the new patient visits over time. However, as you can see on the orange line, the follow-up visits have increased tremendously because our model is to see the patients very, very soon after discharge to take care of any urgent problems and take care of a lot of questions that the patients may have immediately upon leaving the hospital, and to establish a plan for them. But we also like to follow them longitudinally, and those started to really add up, which is a barrier that we found, or hurdle that we found, really by year 2 or 3 of the PE clinic here. And then we introduced a nurse practitioner here that we trained and had her follow up a lot of the more longer term follow-up patients that just required essentially anticoagulation management, and that's why you're seeing our follow-up patient visits are now trending down. As you see, our projected numbers here are a little bit lower, where that also opens us up to allow us to see more, to see many of the new patients that are oftentimes much more complex, which we found is a good model that has worked for us. I think as mentioned in the previous talk, but it does help, the PE clinic does help a lot of different groups that are involved in healthcare. So first and foremost, the emergency room discharges. So I guess piggybacking on Dr. Aggarwal's messages from earlier, if the emergency room has a patient that they diagnosed with a low-risk PE and they would like to discharge them, it increases confidence tremendously to have a home for these patients. So that's kind of where we start our care. I know it can work differently potentially in other systems, but we'd like to start our care essentially right after they leave the emergency room or the hospital in general. And we are able to increase confidence in the emergency physicians in having a place to send them and have reliable, speedy, and high quality follow-up for those patients, which really helps, like I mentioned before, length of stay for the patients, and just helps decompress the hospital in general. Hematologists, outpatients, were getting a lot of these patients as well. So they were being asked to see patients with acute pulmonary embolism in rapid order, especially if they wanted to discharge them relatively quickly from the hospital. And they were starting to get overwhelmed as well. Inpatient medicine, neurosurgery, or surgery teams are among our most common referral bases. And again, for similar reasons, there's maybe a patient where there's a question of what to do with the anticoagulation. There might need to be coordination of care with bleeding risk and with potential incoming surgery or planned surgeries. So we would be able to help them coordinate a lot of that care, and this way they're able to discharge the patient in a confident fashion. Primary care physicians also have been some of our referral bases. They tend to be very comfortable with kind of run-of-the-mill pulmonary emboli, depending on obviously their background and their training and their time constraints. But oftentimes they may not be as comfortable with some of the more complicated cases, or they're wondering if the patient requires further intervention, as I mentioned previously, in terms of chronic thromboembolic disease. So they'll oftentimes will refer the patients to us for consultation. And of course, I think patients are also they give us great feedback in terms of seeing somebody who sees the majority of their outpatients that have pulmonary embolism allows us to have some facility with the conversations, kind of predict some frequently asked questions, and also have them, some patients just don't have any outpatient care whatsoever, and now they need to start getting plugged in, and that's where we can fill that role for them. So how do we do it? So this creating this talk did allow me to, or kind of forced me to look through what are the things we've done over the past few years that have worked. And what we found is over the time we've tried to meet people where they are in terms of referral bases, and we tried to make an easy and reliable referral process. So we created this, as you can see and highlighted here in this email, a distribution list for the PE clinic, which goes to both myself and Dr. Dweck, as well as to our support staff that helps schedule the patients. As you can see, this is a very relatively recent referral that I was able to share with you. Again, somebody from the Department of General Surgery who had a patient that relatively complex, at least for them, and they thought that the patient would need some close follow-up in our capable hands. So they sent us a referral through an email. So that's one way that we were able to create an easy, reliable referral process where we're all on the same page by sending us an email with the patient's name and medical record number redacted here. But that's not the only way to reach us. Another way to reach us would be, oh, there we go. So on our website, which seems to be a top hit, at least for me, anytime I search for anything, but that may be because of the algorithm. But if you go to our website, for the hospital's website, under conditions, you can search by different conditions that you may have. And we have a website dedicated to pulmonary embolism that already existed prior. And that will allow even a patient to kind of self-refer and find a doctor and schedule with one of our PE specialists here. And that includes not just us, but also vascular surgery and thoracic surgery and hematology, etc. And then I think this was also, looks like Henry Ford also uses Epic, I think, but we also have a similar button that says ambulatory referral to the PE clinic. Unlike Henry Ford, though, this only goes to us here at the pulmonary outpatient office. So it will not go, it's not a multidisciplinary referral, it's just the way we do things here. And we were able to gather data as to how many times this has been used. And you can see since we implemented this option in January 2025, that there has been a steady influx of PE referrals through this link. Part of the thought process here was, I believe a lot of the inpatient teams or outpatient doctors will use the Epic referrals for a variety of specialties. So if you're an inpatient doctor and you want to refer the patient to primary care, you might use this. Or if you're an outpatient primary care doctor, you want to refer the patient to a hematologist, you may use ambulatory referral button. So we felt, why don't we just make this for the PE clinic so people understand that you're not referring the patient to just anybody, but you're referring them to a place where we can essentially take over care for this particular disease process. And we've gotten good feedback on this as well. Where are we located? So this is our building on the corner of East 17th Street and 2nd Avenue. As silly as that may sound, that is an important thing for us. So where we do a lot of our ICU time is in this building. So the fact that we have an office that's located in our ICU building was actually pretty essential to the success of the program because during our ICU shifts, we are able to, since we're in the building anyway, we're able to do overbooks and have patients that just left the hospital, let's say 2 weeks ago, see me in the office today in follow-up to ensure that they don't have any gaps in their care. What do we do once the patient gets into the clinic? So we created a smart phrase based on PE guidelines as well as conversations between the two of us, first of all, and also with our PE interested colleagues in hematology to standardize the process and ensure consistent decision making and create a more structured approach. I think this is it's hard to do that in PE sometimes because down the road when deciding, especially deciding on anticoagulation duration, anticoagulation choice, it can be a lot of the guidelines are very vague on what exactly to do and when to do it. So we decided to create a smart phrase so that at least we would be collecting the same data and we can try to ensure relatively consistent decision making and a structured approach. So what goes into it? These are some of the factors that go into it. When we collect the risk of the initial PE, so was the initial PE a very high risk pulmonary embolism because they received CPR, for example, or was it a very low risk pulmonary embolism and maybe they were discharged, from the emergency room? So those obviously those patients may be treated a little bit differently down the road. What choice of anticoagulant was chosen for the patient after they left? So if they have antiphospholipid antibody syndrome, were they placed on warfarin, or are they using one of the other direct oral anticoagulants? What are the risk factors for recurrence? So if there's a strong provoking factor, for example, like they just had some kind of surgery, that would be a strong risk factor, and that helps us decide what to do with the patients after the initial treatment phase. Is there a weak provoking factor? Did the patient lie in bed for 48 hours with a upper respiratory infection, for example? Or are there any persistent risk factors? For example, does the patient have a very elevated BMI, or do they have some sort of autoimmune condition? That helps us plan for the duration, and we kind of force ourselves to plan for the duration off the bat when first meeting the patient. One of the things that the PE clinic has kind of taken on itself is age-appropriate cancer screenings, which of course, if there's a patient who's 60 years old and has an idiopathic pulmonary embolism but has never had colorectal cancer screening, for example, then it would be important for us to know whether they have that or not, because that could also lead to be a risk factor for recurrence as well. So we're very aggressive with age-appropriate cancer screenings for those patients, depending on who it is. And this is just something that we did research ourselves. So a little bit, I'm going to go through the slide a little bit. If you look on the left side, this is just after they saw us. So prior to seeing us, this is gray bar on the left. 42.31% of the patients who we saw at initial diagnosis had completed colorectal cancer screening who were eligible. If you go to total after 12 months, and you can see each month by month, more and more would be getting screened. But if you go to the total after 12 months, now our rates are essentially where they are for the national average of adults age 50 to 75. So our delta was 29.48%, or a 69.68% increase in colorectal cancer screenings just by visiting our post-PE clinic. So just one of the ways where we were able to improve the care of many of our patients, and obviously the reasons why this is not 100% are variable, but trying to get at least the patients who are well below the national average to at least 29% difference in colorectal cancer screenings has also led to some very nice success stories, like catching a colon cancer pretty early. We've caught other cancers early as well, but those are a little bit less easy to study. So we decided to report our colorectal cancer screening rates. So going through this process has led to a lot of lessons learned, and I would like to share them with you, just in case you are experiencing some of the same problems or can be prepared for the future. So one of the gaps was how much medication has been prescribed. Some inpatient teams will only prescribe anticoagulants for, let's say, 7 days, or some others will prescribe for 30 days, others will prescribe for 90 days. So since it was so variable, we did train our staff in auditing how much medications do the patients have. So for example, if the patient only has 7 days left of their medication, but we were planning to see them in 14 days, then will that patient have any medication between day 7 and 14, or will they be missing it because there's nobody to prescribe it to them? Does the patient already have a pulmonologist or another specialist? So if the patient already has a pulmonologist or a hematologist, for example, maybe they had a cancer-associated thrombosis, do they need to see us, right? So that we trained our staff to kind of look through that and see who have they seen in the past, and that helps us decide: is the patient going to come here and say, "What am I doing here?" Or are they going to come here and or do they not need to come here at all? Or do the pulmonologist that's seeing them want to focus on their asthma, and now they want us to kind of take over the pulmonary embolism piece, which happens relatively frequently. Questions prior to the appointment. Yeah, so this is another frequently asked question that we kind of come up with, which is, let's say they leave the hospital, on Tuesday, and they're seeing us on Friday. So, but then on Wednesday, they have a question for us. So they have a question about their care, about their medication, or about a side effect. So how do they reach us? So unfortunately, with Epic, which is the electronic medical record that we use, The patients have no way to send us a message through that system, through that app, um, without having established care with us already. So if they lucky enough to have a primary care physician, for example, then of course they can, or another provider that's comfortable with this, they can of course send them a message, which happens frequently. But our plan, and we're kind of in the nascent stages of this, our plan is to make a video, which this is an idea that we actually got from our orthopedic colleagues. So, for example, at our hospital, if you get a knee replacement, then when you're under anesthesia and then you wake and you're kind of coming out of anesthesia and everything kind of went well, your surgeon used to come up to you and tell you, "Hey, everything went well. I'll check on you later." And then 2 hours later, you may have forgotten that entire conversation ever happened. So, what the orthopedic surgeons have come up with is they will record a video on the app and send it to the patient so that when they come to, if they have any specific instructions, for example, don't move your leg this way, don't move your leg that way, they will have the answers to those questions in that video and they could reference it at any time. So our plan, Dr. Dweck and myself, is to make a video for these patients of essentially frequently asked questions that we've come across that will help them kind of allay some of their concerns and to minimize anxiety around the period between hospital discharge and the first PE appointment. Our emergency department also has a system in place already for follow-up calls for any patient that has left their emergency department that meets certain criteria that are considered to be high risk. So this is the criteria that they've given us. So this is not PE specific, but any patient on anticoagulation or age greater than 65 with a chief complaint that's cardiopulmonary will receive an outreach from the follow-up center from the emergency department within 24 to 48 hours. So as you can imagine, that's essentially most of our patients that will automatically get called or texted, and to make sure that they don't have any new symptoms that are concerning, and B, that they don't have any questions about, let's say their anticoagulation is new and they don't know what time to take it or what food to avoid. They will have those questions answered in a rapid fashion. So that does help us significantly in terms of bridging the gap there between discharge and first visit. All other patients that don't meet that criteria will receive a clinical questionnaire within 24 to 72 hours, and then they could also opt into a call. So if they don't meet the criteria, but they still have a lot of questions, and the questionnaire is sent out, they're able to give us that feedback that they would like to speak to somebody from the emergency department. So about 24 hours after discharge, a nurse from the ER will call them and say, this is a direct quote, "I'm a nurse calling from NYU Care Coordination and hope you have returned home safely to rest and recover. We want to make sure that you were able to get settled at home. May I ask how you are doing?" So they're trained to essentially give some open-ended questions first. And then they go, and you see number 2 here, they go a little bit more specific. Do you have your discharge instructions available to review? Let's make sure everything planned with the hospital team is in place. So the after visit summary or the discharge instructions they receive will then be able to be confirmed and make sure the patient does not have any misunderstandings about them. And then finally, let's review all of your medications and whether or not you are taking them. This is not the entire script, but I just took out some of the salient points here. So you can get a sense of what kind of phone calls the patients are getting in between, as this tends to be a relatively high risk period. Our co-collaborators are also key to the success of the PE clinic that we have here. Dr. David Green from hematology has been traditionally the hematologist here that's been the most interested in kind of benign hematology or anticoagulation. So he was helpful with us in the beginning in terms of creating some of the protocols and standardizing some of the processes so that they wouldn't go to one doctor and get one recommendation and then go to a different doctor and get a totally different recommendation and then end up confused or lose trust in the system. So Dr. Green and us have gotten together and created some sort of formal pathways. Dr. Justin Chan from thoracic surgery has also been crucial for us in terms of any patients that do have chronic thromboembolic disease down the road and require pulmonary thromboendarterectomies, for example. He and our colleagues in pulmonary hypertension do a great job in terms of collaboration and helping us determine which patient and what treatment they're indicated for. And of course, the anticoagulation clinic at our ambulatory care center. These are all off-site, but ambulatory care center is the home of the anticoagulation clinic, where there are trained NPs that deal with this for essentially any patient. So they have also been key in terms of, let's say a patient has a DVT but no PE, then oftentimes the anticoagulation clinic is the place for them to start so that they can make sure that they're getting the medications they need and prevent any propagation of the DVT into a PE. Thank you for listening to the presentation, and I think it might be time for some Q&A.
Yes, thank you so much, Dr. Bondarsky, for another excellent model share. It was so impressive to hear about the work that you all are doing at the clinic. I am going to now ask both speakers to come back as we transition to the panel portion of our session, where we'll take a deeper dive into each of our speakers' experiences and explore their PE programs and clinics in a little bit more detail. I'll be moderating today's discussion. So to kind of start us off, both of your model shares and programs have really shown a consistent theme in the multidisciplinary collaboration. And we know that one of the key factors of building a successful PE program is just that. So from both of y'all's perspectives, what are the specialties that are essential for a strong PE response team, and how do you bring stakeholders together across all the different departments?
Sure. I think your question was about a PE response team or a PERT. I actually neglected to mention that, but the PERT team at NYU may work different. So I used to work at a different institution, and I see that the PERT teams can be activated in a variety of different ways depending on what works for an institution. At NYU, we have a Send Word Now program that will automatically call all of the relevant parties. So for an inpatient PERT, what that means is for us, somebody from intervention. For us, it's interventional radiology, actually. I know in a lot of places, interventional cardiology, but somebody who will do an intervention in terms of catheter-based interventions. Somebody from thoracic surgery. So you had seen a picture of my colleague Justin Chan earlier. So he would be the surgical thrombectomy portion. And we have somebody from critical care to determine essentially area for observation. Very rarely, I mean, as part of the greater PERT team, right? So we would need like maybe hematology, or we may need pharmacy. Those would be important to have as part of the greater system, in my opinion. But in terms of on that initial PERT phone call, I would say somebody that can perform surgical thrombectomy, somebody who can perform catheter-directed interventions, and somebody who can determine level of care for that patient.
I would say the same thing, Eliza. We do it. So at Ford, our PERT team is essentially we have an inpatient pulmonary hypertension consult service, which also doubles up as the inpatient PERT team during the working hours, and then in the evening we have one dedicated person who's on call. So at any point in the night, we have 4 critical care attendings for the ICUs that we cover. So one of them is assigned for PERT. And as far as the way it works over here is, the operator has a paging system for PERT. That page goes out to the person assigned for PERT, and that person, the pulmonary hypertension team is multidisciplinary, so it could be a cardiologist or it could be a pulmonologist, but that person makes the first initial assessment. And then we have this thing called a PERT 2, which is generally an interventional physician who can offer interventional therapies. And if the PERT 1 feels this is a patient that warrants a discussion about interventional therapies, then they bring in the PERT 2 person, and we actually split it so 1 week at a time, half and half between interventional radiology and interventional cardiology. So 26 weeks are covered by IR, 26 weeks are covered by interventional cardiology. And then we have a discussion. And then if we think that we need to engage, let's say there is clot in transit, or if there is a massive PE that we think may require open surgery, in those rare circumstances, we call it PERT 3, in which we engage with a cardiac surgeon. So it's a layered system. All the calls go to PERT 1. PERT 1 reaches out to PERT 2 for some of them. And then for the rare super high risk cases, we bring in cardiac surgery.
Thank you both for sharing those perspectives and kind of thinking about maybe a little bit more on the operation side of building a PE program. We know sometimes that could be the most challenging aspect of it. What were some of the biggest workflow challenges during implementation, and what kind of tools and technologies helped really streamline operations?
You want to go first, Eric? You want me to go first?
Go ahead.
Sure. So, from my experience, as small as it sounds, but the hardest part was to get the IT people to build a dedicated ambulatory referral to the pulmonary embolism clinic order done. There were a lot of questions asked from a lot of different people. What is this? Why are you doing it? So why can't this be under pulmonary or hematology or cardiology? And what is the point? So it just required a lot of patience and persistence. I think at the end of the day, we were able to achieve it at this institution just because we started the process by going to the leadership, both in cardiology and pulmonology first. And we got them to buy in, and we got them to agree that we need a standalone order that is specialty agnostic, so that it's easy to find. And then, so when the other challenges came with all these other people asking for all kinds of things, if your leadership is with you, then it's a lot easier to push it through. I would say that was the hardest piece. Apart from that, you just have to bring everybody engaged, on with you. Like we had to recruit a cardiac surgeon from Cleveland Clinic to do pulmonary endarterectomy. We recruited one more pulmonary hypertension doctor, so now we are up to a complement of 6. A dedicated nurse, a dedicated nurse coordination. But you can make a case for that if you have the right business people that can pull up and help you develop what they call a return on investment proposal. So you have to build an ROI. And that wasn't too hard. It was more the logistical challenges on the ground. Now that we've had it, it's sort of spreading, and more people are using it, and we just continue to see more and more of these consults coming in. So the biggest challenge is to just, it's a machine that keeps asking for more fuel. And the more fuel you give, the faster it runs, and it asks for more and more. So just keeping, just to keeping it up to it. We do have a red cap that collects all the patients in a registry. So that's like the latest piece to the puzzle. And I would say anybody who does it should also do that, because that's how you're going to be able to learn from, what you are going through and how you do it better. So, yeah.
Yeah, I just to piggyback off that, I totally agree. I think getting part of our challenges was to get the Epic Smart phrase, for example. How did we build it? What do we put inside? How should it look? Should it be clicking buttons? Should it be free typing certain numbers? So those things did take some several consecutive meetings to kind of put our heads together and figure out what we wanted to put there. And then also meetings with IT, which is sometimes hard to get their attention, but meetings with the right people in IT to get those in. Yeah, I think that I would agree with that.
Thank you so much, and definitely agree. And thanks so much for being transparent and some of the challenges that could come across when you are, trying to operationalize and build a successful PE program. In our last session, we, talked about the PE guidelines and how, sometimes there's guidelines, sometimes there's standardized protocols in, in your hospital. How do you balance standardized protocols with individualized patient care?
If I may, I think a lot of the guidelines they leave it vague essentially for that reason, right? So if you look at the latest guidelines, there's a lot of sentences that say things like "it is reasonable to" or "is reasonable not to," or shared decision making with the patient. So these things leave open the reality of the situation, which is that every patient that has suffered a pulmonary embolism may have different comorbidities, different bleeding risks, different clotting risks, different lifestyles, different support systems. So those things all need to, and different anxieties. I mean, there's definitely that component to it where um, if you've just experienced a blood, a pulmonary embolism, a blood clot in your lung, you don't really know what it is, and somebody in the ER maybe told you that you have a high risk of mortality from it, and now you come out of it, and all you want to do is have the security blanket of the blood thinner for the rest of your life, right? On the other hand, you have patients that come in and say, I don't like medication. I never took this before. Why are you making me take this for so long? So definitely balancing each patient's individual concerns and personalities and anxieties, and of course educating them to have an informed decision about why we're doing what we're doing, but also working with them to make sure that there's a therapeutic relationship.
I would say the same thing, Eliza. It's just the big thing is you just have to be the doctor at the bedside.
Right.
The guidelines are there. It's one piece of, it's a tool you have. You can use it, but you just have to stay up to date and just do what you think is best for that patient.
Yeah, absolutely. And I totally agree. Meeting patients where they are. Dr. Bondarsky, you said that in your presentation as well, and when you highlighted, the location of your clinic. So, no, really appreciate your responses to that question. When we think about, our high risk PE patients, how are advanced therapies like mechanical thrombectomy being integrated into your care pathways? We know it could be a little varied. It could be varied in what specialties are doing these more advanced therapies, but how have you all been able to accomplish it? And then second, how have you built multidisciplinary consensus around when to use these interventions?
Can start with that. So when you say high risk, you're talking about the high risk PE, right?
Correct.
Yeah. So for high risk PE, we have a protocol where, depending on where the patient is, we sort of pick a therapy. So if the patient is in a hospital, we have a 14 hospital health system. So if a patient is in a hospital that can essentially do cannulation with MCS or ECMO on site, then our protocol for high risk pulmonary embolism, so patients that are in refractory shock, is to cannulate before giving them systemic lysis. If you are not able to do it at your hospital, then we still say go for systemic lysis. We do not recommend systemic lysis on a patient that's getting active CPR. But once you establish there is a return of circulation, then it's reasonable. Beyond that, as far as mechanical thrombectomy goes, if you're able to stabilize them on ECMO, then the next step is usually taking the clot out. And we don't recommend using catheter-directed lysis or systemic lysis if somebody is already on ECMO. In those patients, I think thrombectomy is probably the only tool. Because if you give somebody TPA, despite when they're on ECMO, the risk of bleeding is exponentially higher. And then if somebody gets cannulated on ECMO at any of our sites, they all get transferred to the hub downtown. The ECMOs don't stay. And we've had some good luck with it. The other challenge is to identify high risk acute pulmonary embolism from high risk acute on chronic or chronic pulmonary embolism, because patients with CTEPH will present with florid right heart failure and cardiogenic shock. But that's not a high risk acute PE that needs systemic TPA. That's more like you have to give them diuretics, inotropes, pressors. And then if they don't respond to it, you have to cannulate them and then take them to eventually a pulmonary endarterectomy or balloon pulmonary angioplasty. So that's also a big discussion. So decision point, are they in shock from the acute clot, or are they in shock from the chronic clot, or are they in shock from something else? So that's how we do high-risk PE.
Yeah, the only thing I'll just add to that is that a PERT discussion is now finally been immortalized in the latest PE guidelines from 2026. So I think the class one recommendation to use a PERT in the high risk or intermediate high risk settings, I think speaks to the fact that each individual case is so nuanced that without having people who deal with this condition frequently looking at, or at least delving into the details of that patient case, it's very hard to make sweeping recommendations. And of course, the fact that each institution will have interventionalists with different levels of comfort also plays a role into that as well.
Yeah, that's key. Yeah, all these discussions have to happen. So within your PERT team, yes, 100%.
Yeah, absolutely. Having that discussion within that team, totally agree. Thank you so much for those insights. Dr. Aggarwal, you in your presentation, you talked about how you were able to get some leadership buy-in, and in one of your panel answers to kind of talked about the ROI of how to build a system and getting leadership buy-in. Dr. Bondarsky, I'd love to hear from your perspective on when you all were trying to get your program off the ground. How did you secure leadership buy-in, and kind of what specifically helped you gain support? And is there anything else that you would recommend or maybe do differently now that you kind of went through it?
So in terms of leadership buy-in, we weren't asking for much really in terms of resources. So it was more, they were just very happy to have a place that we were willing to be the home for these patients and take ownership of this condition. So we didn't have a lot of ROI type questions because there was not really much being invested into us. A lot of things that we would have wanted have already been in place. So like I said, the ED phone calls, the anticoagulation clinic with nurse practitioners that are specially trained in dealing with anticoagulants and their intricacies. So those are the things that we would have had those hurdles had we not had those in place already. So we were lucky to have those already in place. The pulmonary hypertension program here and the CTEPH program in general is also very well supported by leadership already. And that, again, that started before we started the PE clinic. So I feel lucky that we were able to enter onto the scene with those services already in place.
Thank you so much for sharing that. Dr. Aggarwal, is there anything else that you would add in terms of leadership buy-in or getting, admin onboarded onto your PE program?
The only thing I would say is you can't just go ask for things. You have to first show the value. And, if you show the values, most people get it.
Thank you so much for both of y'all's insights. So one last question for the panel discussion, and then we'll go into some Q&A because I do see some popping up in our Q&A box. But, what advice would you give to, any other hospitals who are just beginning this journey? Maybe they have like ad hoc PE, calls. Maybe they don't have, an established team, a PERT team, or established program. What kind of advice would you give those type of hospitals?
I'll take this one, I guess. So the advice is just, I think, just get started and just do what you can do. Don't try to do a carbon copy of some other institution's pathways, because every institution is very unique and has different strengths and weaknesses and soft points and buy-ins that just I think getting started with anything is the way to go. And then as you can see with the lessons learned that we weren't perfect when we started. We were far from perfect when we started for sure. And then just trying to slowly improve each spot, each deficiency as we go along is how every program starts and grows. So don't let perfect be the enemy of better. So just improve slowly, start somewhere, and then there's a patient that's getting a PE in your hospital probably today that you probably could benefit if you start today. So that would be my advice.
I would say the same thing.
Thank you so much, Dr. Aggarwal. So that kind of ends this panel portion of our session today. Thank you so much, Dr. Aggarwal and Dr. Bondarsky, for such an engaging discussion and offering such great real world examples and strategies, your insights are so helpful for teams working on improving their PE programs. We'll now take a few questions for our speakers from the audience. I do see we do have some already, but if anyone thinks of more questions, feel free to drop them in the Q&A box found on the bottom of your Zoom panel. Let's start off with one of these questions. So this is a question from the audience. Do your organizations have dedicated resources for PE, like a PE coordinator? Dr. Aggarwal, they were talking about you, and they have a chest pain coordinators to support STEMI. They have stroke coordinators to support the stroke program, but maybe not all hospitals have a dedicated resources for PE. So wondering if this is something that either you all have or something that you've looked into.
We have a dedicated nurse practitioner for all the inpatient parts. She works 5 days a week, 8 to 5. And then we have a nurse coordinator that sort of quarterbacks the PE clinic and sort of triages all the referrals that come in and schedules them and all that stuff. And I think those are needed. And if you show the value, you can do it.
Our clinic was, a standalone general pulmonary clinic before it became a PE clinic. So our front desk staff has kind of morphed into the role of a PE clinic coordinator, at least in the outpatient side. I don't believe there's anybody in the inpatient side that plays that role, at least in our institution. However, because we're one of the sites of the PE tracked trial, and which is, I believe, like 3 or 4 patients away from finishing enrollment, a lot of our intermediate high risk or high risk PEs are being enrolled in that trial, and there is a research nurse that will help coordinate a lot of the outpatient care in terms of randomization, as well as just outpatient follow-up and testing, such as CPET.
Got it. Thank you so much for answering that question. Another question that we have from the audience is what type of, or if type of AI tools have you all used in implementing your PE program?
We don't use any AI tools. We used one of those softwares, Rapid AI, a few years ago.
Yeah.
Honestly, we didn't see any added yield. We were not missing any PEs in this hospital. So we don't use them.
Got it.
I would say something similar at our institution, except in the outpatient clinic, at least, where I found it to be very helpful is if you have an outside referral and they instead of being seamless into our electronic medical record, they might have a scanned document of 78 pages from an outside hospital from when they were, like, we had a patient recently from Japan, for example, that had like 78 pages of just their hospital course there. And normally what I would be doing is leafing through it and trying to figure out what risk was there, what was the troponin, what was the BNP, et cetera. But this way I was able to put the document to AI and ask it the question that I'm looking for by combing through the document, and it spit out exactly what I wanted, which saved me a lot of time, and at least for that one case. And this happens relatively frequently for patients outside the system. But no, other than that, we're not using AI for anything fancier than that.
Got it. Yeah, and we've definitely seen kind of a split between using AI for PE care, but definitely something that is an emerging topic in this field. Let's move on to the next question. So we have a question from the audience. Do you have any best practice proactive protocol to prevent inpatient PE that you could all share?
Talking about like DVT-PE prophylaxis when the patients are admitted?
Yes, yeah, that's what it seems like, any inpatient.
Yeah. I'm sure they have it in hospital medicine. I just don't know.
Yeah, I will say my main ICU where I do most of my critical care time is actually an orthopedic hospital. And I will give a lot of credit to the orthopedic kind of community in general. The amount of post-op PE or DVT that we've seen, because of very aggressive and early prophylaxis and mobilization, and because of shorter tourniquet times, because of shorter OR times, and just choosing the right patient, I think also. But all those things together have made the orthopedic place, which used to be a huge source of VTE now has essentially disappeared. I mean, it's not quite zero, but it's shockingly low compared to when I started here. And kudos to those to surgeons who are doing important operations, but obviously are thrombogenic, that are keeping their patients safe in that fashion.
Thank you so much for sharing that. One of the last questions that I'm seeing from the audience, what were the challenges engaging the ER? And where did you see the engagement change for the better? Was it 3 months in, 6 months in, one year in?
Engaging the ER was not hard for us. They were very responsive and they loved the fact that we had not only an inpatient PERT, but also an outpatient PE clinic. I did go to each individual ER in our health system, and they have a monthly meeting. Pretty much every ER group will have a monthly meeting where they do their M&M and their just it's a day-to-day faculty meeting. And I did make a presentation, but once we had that epic order all good to go, it wasn't hard to disseminate it.
Yeah, I had a similar experience. This is the ER loves this kind of stuff. I think they love a group of people that are going to provide high quality and reliable care to patients. So when they were involved with this, it was a very seamless integration. And of course, it helps them not have to admit a patient sometimes if they're able to just press this button, or send this email,
That's
or
right.
call this number, and then now you can go home. For them, it makes them much happier to declutter their ER for patients who are better served at home.
Yeah, and we have to remember that pulmonary embolism is a real, from a medical legal standpoint, it's a real worry for the ER docs, and they don't want to, a lot of times these patients are admitted, quote unquote, to make sure, and so giving them an out where they can say they send the patient home with a dedicated follow-up in a pulmonary embolism specialized clinic makes them feel a lot better. So that's
And
not
like
good.
you and like you said, protects them medical legally as well,
Yeah.
right?
Yeah, no, that's a really great point. Thank you so much for answering that question. And I think one of the last questions that we'll just wrap up today's session with is, for sites that may not have the same level of resources, what do you think are maybe 1 or 2 high impact steps that they could take early on to start building that strong PE program? Dr. Bondarsky, you kind of started to allude it. Sometimes you just gotta kind of have to get started. You said a great quote, don't let perfect be the enemy of better. So yeah, what kind of, high impact steps would you recommend?
I just think availability, right? So, like I said before, meet the patients where they are, or meet your hospital system where it is, like whatever works well for your hospital system, whatever their usual method of discharging patients is. Try to work with that and say, okay, well, I'm available every Wednesday afternoon from this time to that time. Here are my appointments, and then just start seeing patients, and you'll build expertise first, and you'll build confidence and reliability very rapidly, I think.
Yeah, I would agree. Access is one. You have to create access first. And number two, you have to look all around you and identify everybody who's interested and engaged in this disease process and, in this stuff as you are, regardless of their specialty. And you have to pull them through. And then just start somewhere and
Mhm.
to build up I agree with everything Eric said. It's never going to be a perfect program on day one, but you got to start somewhere and then just build up on it.
Absolutely. Thank you so much for your answers. And thank you again so much for being part of this session. I know we asked you many questions throughout today's discussion, but it was a great session just for, anyone who may be, wanting to improve their PE program, or, maybe they're building it from scratch, and just to have y'all's insight has been so invaluable to us. So thank you again to both of our speakers, and thank you to the audience for your participation and sending in those questions. Now, coming up next at 1:30 p.m. Central, we'll have our last session of the day, straightening PE care pathways through ED relationship building. Please return to the lobby to access this session using the menu at the top of your screen. From the lobby, click on the Sessions tab first. Then you could click on the individual session to join, or you could also click on the link that was just posted directly in the chat of this session. I know we're a little earlier, so we just wanted to give you all, maybe a 10-minute break until our next session, which is in about 10 minutes. So we will see you at the last session. Thank you so much for attending session 3 of the forum, and we'll see you shortly. Thank you.